I keep forgetting when I'm rolling with Senator Braun that he is fashion forward, on time, tireless, and he is what the Senate should be, although I hear he may be leaving me to another job future in the soon, which, you know, as a person with an abandonment problem, I feel already sad. But I'm really grateful to be here, and I want to begin by heaping more praise on Senator Braun. Early when he and I, in this Congress, when he and I both got this post as chair and ranking, we talked a lot about our common ground, and this idea that the private sector was doing a lot to reduce prices really intrigued us a lot, as well as increase health. And so I want to thank the witnesses that are here. I want to let you all know that we have been, as a team, focused on the nutrition crisis that our country is facing. Oh, I'm sorry, all this officialness. We have begun. How's that? Good? Does that satisfies it? All right. Senator Braun and I have been focused on the nutrition crisis, and I want to start today by reminding our audience of the scale of the crisis we are facing in America and the explosion of diet-related diseases. Currently, in the United States, half our population is pre-diabetic and has type 2 diabetes. Each month, diabetes causes 13,000 new amputations every month, 5,000 new cases of kidney failure, 2,000 new cases of blindness in our country. And that is something that isn't exclusively affecting older people. We are seeing growing rates of diabetes in our youth as well. 1/4 of our teenagers today are pre-diabetic or have type 2 diabetes. Much of that can be attributed to the alarming fact that ultra-processed foods now compose 2/3 of the calories in the diets of our children and teens. It's estimated that half of all children today will be obese by the time they are 35 years old. Half of all children today. Broadly speaking, diet-related diseases, chronic diseases, are now the leading cause of death in the United States. According to the FDA, on average, 2,700 people die per day from diet-related diseases. And the effects of diet-related diseases are not limited to the healthcare field. They are causing an economic crisis that is spiraling out of control. Nearly 1 out of every $3 in the federal budget now goes towards healthcare spending. In 5 years, the healthcare costs of type 2 diabetes alone has risen 25% to a staggering $237 billion. This is simply not sustainable in the long term. Right now, it is imperative that we embark on a whole-of-government approach to address diet-related diseases. And one of the most promising solutions that we can adopt is something that is alluded to in the 2,000-year-old writings of Hippocrates. And it is rooted in the practices of many of the indigenous communities in our own country. It is the idea that the food we eat is intrinsically tied to our health, the growing recognition that food can act as medicine. Researchers, healthcare professionals, farmers, policymakers across the country are already putting this idea into practice and achieving successes. Let me take you back in time. When I was mayor of Newark, one of the challenges we faced was the fact that many communities in our city were suffering from food deserts, places where residents didn't have access to healthy food. We did many different things to address this crisis, including starting to grow more fruits and vegetables and distribute them locally in our city. One of the projects was the creation of the largest urban farm in New Jersey, a multi-acre farm on an entire city block in a low-income neighborhood. I recently went back and visited that farm. While there, I met 2 women who came up to me and told me their stories. The first one said that she had been having gastrointestinal issues. For the treatment, she was paying $100 per month copay for medication. The federal government took on the remaining cost of $600 a month for her prescription drugs. She was able to change her diet by taking advantage of the GusNIP program run through the New Jersey-based nonprofit City Green, which allowed her to double her SNAP benefits for the purchase of fruits and vegetables. When the woman used GusNIP program at the community farm to incorporate substantially more fruits and vegetables, she saw her gut issues disappear. The second woman was in her 80s and was a diabetic. After she began to source the majority of her food from the farm, she told me that her diabetes went away. And those two stories are not anomalies. We hear today from our witnesses about how food as medicine programs can be transformative for the health of individuals and families receiving foods, as well as lowering costs. We'll hear how these programs can lead to that healthcare cost savings and the savings of human misery. Finally, our witnesses will testify how programs like GusNIP, Double Bucks, and produce prescriptions can be transformative economic opportunities for families across the country. These investments are enabling farmers to grow healthy food for their neighborhoods and are helping to build resilient local and regional food systems. I'm encouraged to see the federal government begin to recognize the promise of food as medicine. In September, as part of the White House Conference on Hunger, Nutrition, and Health, which Senator Braun and I led the call for, the White House released a bold blueprint to end hunger, improve nutrition, and reduce the epidemic of diet-related diseases. A key component of the national strategy is a call to continue researching and scaling up of food as medicine programs, such as funding pilot programs to integrate medically tailored meals and nutrition counseling into our Medicare and Medicaid programs. Although these are promising steps, we also need to integrate food as medicine strategies directly into our FDA programs. And so this is a top priority for me in the Farm Bill. Will be to increase the incentives for farmers to grow fruits and vegetables to a level that we currently support in commodity crop production. Our dietary guidelines tell us that 50% of the food we should eat should be fruits and vegetables, but less than 10% of our Farm Bill subsidies currently go there. And so the number one, we must substantially scale up programs like GusNIPs. Number two, we should create a new USDA specialty crop food box program to provide locally sourced fruits and vegetables to Medicaid participants. And I look forward to working with senators on both sides of the aisle on these common sense, pragmatic steps to make for a healthier America and lower costs in our federal government. And so I'm excited about the witnesses. I'm excited about the insights that we're going to hear. And I want to recognize my friend and someone who has been such a strong partner on these issues, Senator Braun, for opening comments that he'd like to make.
Thank you, Mr. Chairman. It is interesting when you come together on a topic like this that should be so obvious to everyone that an ounce of prevention is worth a pound of cure. We've been at it, with the White House forum that was put together, but I go back to when I was a CEO. I did that for 37 years prior to becoming a senator. And it was 15 years ago when I said, enough is enough with how lucky I am that my health care costs are only going up 5 to 10% this year. So I had to do something, just like you did as mayor, that was going to take a dynamic that was built in and try to change it. Very simple. When they told me that so much of the health insurance cost is not a catastrophic accident or a very catastrophic disease, it is the minor health care that you overuse and use too much of due to type 2 diabetes, heart conditions that brew over a long period of time. In a nutshell, I took all that because I was frustrated, and we built a system based upon wellness and avoiding the healthcare system and making my employees engage in their own well-being, created the incentives, gave them a free biometric screening. If you didn't get it, you were going to get penalized because you weren't doing the right thing. We did all of that, and all I can tell you is I checked just to make sure how we were doing since I haven't been there for a while, thinking we were eating a lot of cost increases. Employees have not had a premium increase in 15 years, and they go into their deductible less now than they did then because they've become healthcare consumers. In a nutshell, that's what we need to do more broadly across the country and try to incentivize that through this committee and how we can just get that word out, again, that an ounce of prevention is worth a pound of cure. According to the CDC, 9% of Americans do contend with type 2 diabetes. 33% have pre-diabetes. American Heart Association, half of American adults have cardiovascular disease or hypertension. two of the easiest things to treat, number one, but even before you get into a treatment, you can avoid it by lifestyle changes. If left untreated, they become a significant healthcare consequence. Nutrition and wellness are the ideas that each of us should incorporate into our lives. Companies need to be promoting it across the country, and at every level of government, we need to be getting the word out. Market mechanisms need to come into play as well. Basically, what I did is create an incentive for my employees to be healthcare consumers, not just telling them to do it, offering those tools of wellness, but created kind of a mini market that got everybody thinking in that same direction. It got people to acknowledge what their own healthcare issues were. They embraced that free biometric screening, and you heard the results. So through employers, through government, we need to all be working in that direction. If not, we're never going to address the fact that healthcare is 20% of our GDP. That is nearly 50% more than almost all other developed countries. And they generate results that are as good as ours. So a lot of what ails our healthcare system is overutilization because we've never changed the lifestyles that take us into the healthcare system in the first place. And that starts with your diet. What you eat is what you are. How we're going to get to the point where we convince all of America, we do it through our agriculture programs currently. We push nutrition. Something just seems like it's not quite working. I think we need to find, with all the money that we spend, over like 200 programs, 20 agencies, there may need to be a focus on this in and of itself. Because like back in Indiana, when we were working on workforce development, we had 20 agencies spending tons of money, not coordinated, never to get to the right results there. Started focusing on it, started getting to some of the solutions on something unrelated, but it was disaggregated. I think here what we ought to strive for is maybe to focus on how we narrow this into something that focuses purely on what's got to be one of the most important things in our society. How do you eat well to avoid the healthcare system in the first place? How do you take care of yourself so that you prevent it before you get there and have to spend a fortune on getting remediated? I yield back.
I thank you for that opening statement. Let the record show that I said hallelujah, amen to his comments. I want to recognize that the ranking member of this entire agricultural committee is here, the powerfully pragmatic pugilist, Senator Bozeman. I don't know if you want to say anything at all, sir? All right, then I'm going to go on and introduce the witnesses, and I'm going to start with Martin Richards. Mr. Richards is the executive director of the Community Farm Alliance in Kentucky, formed from the farm crisis of the 1980s. Community Farm Alliance is a statewide grassroots organization whose mission is to organize and encourage cooperation amongst rural and urban citizens and to ensure an essential prosperous place for family-scale agriculture in economies and communities. Mr. Richards has been an active member of the Community Farm Alliance for over 20 years. You've served as on the board, as board chair, and as executive director since 2010. From growing up in steel towns to Kentucky's tobacco fields and coal towns, Mr. Richards has a long history of working with communities to revitalize their economies. Prior to the Farm Alliance, Mr. Richards was a tobacco and cattle farmer. I want to thank you for being here, Mr. Richards. I'm grateful for you. Ms. Leah Penniman. Ms. Leah Penniman is a Black Creole farmer and mother, author, and food justice activist from Soulfire Farm in Grafton, New York. It's finally good to see you in person. She co-founded Soulfire Farm in 2010 with the mission to end racism in the food system and reclaim our ancestral connection to the land. As executive director and farm director, she is part of a team that facilitates powerful food sovereignty. programs, including farmer training for Black and brown people, a subsidized farm food distribution program for communities living in food deserts, and domestic and international organizing towards equity in the food system. She is a member of clergy in the West African indigenous Orisa tradition, and through her work and Soulfire Farm, she has been recognized by the Soros Racial Justice Fellowship Fulbright Program, the Pritzker Environmental Genius Award, Grist 50, and James Beard Leadership Award, amongst others. Extraordinary. Thank you so much for being here today. Ms. Dr. John Bolger is the Chief Medical Officer for Grissinger. Am I pronouncing that right? What's that? Geisinger, forgive me. My staff told me that 7 times. Geisinger Health Plan, which is statewide, a health care provider and insurance company in Pennsylvania that serves more than 1 million people. I'm just mad that the Giants lost to the Eagles recently. That's why I'm doing this. Dr. Bolger is responsible for working with community partners to improve the quality of medical care for the patients and members of Geisinger Services. Dr. Bolger is a general internist and has practiced in inpatient and outpatient settings. Dr. Bolger earned his Bachelor's of Science degree from Juniata College in Huntington. Help me out here, sir. Come on, I'm failing. I'm sinking here.
Juniata,
Pennsylvania, and his Doctor of Osteopathic Medicine degree from Philadelphia College of Osteopathic Medicine. He also holds a master's degree of business administration from Penn State University. I want to thank you for being here, even though I have butchered multiple times the things you were working on so well. And I want to turn to my ranking member, Braun, who will introduce our next 2 witnesses.
Thank you, Mr. Chairman. Our next witness is Dr. Kevin Volpe, who is founding director of the Center for Health Incentives and Behavioral Economics and the Mark V. Pauley President's Distinguished Professor at the Perelman School of Medicine and Healthcare Management at Wharton. As you'll hear today, Dr. Volpe's work focuses on developing and testing innovative ways to apply behavioral economics in improving patient health behavior and affecting provider performance. He's also worked with groups at nearly every point in the healthcare delivery chain to test the effectiveness of different behavioral economic strategies in addressing tobacco dependence, obesity, and medication non-adherence. Dr. Volpe earned his MD from the University of Pennsylvania's Perelman School of Medicine and a PhD in health economics, public policy, and management from Wharton. Final witness this morning is Dr. Bob Chestnut. Dr. Chestnut serves as Chief Medical Officer at Cummins. Cummins is a great company not too far away from where I live in southern Indiana, Columbus, Indiana. In this role, he works with other key leaders within the company to support the physical, mental, social, and financial well-being of Cummins employees and their families. Sound like kind of what I did back in my company. Love it. Previously, Dr. Chestnut leveraged his expertise in occupational and environmental health to shape Cummins' strategy during the pandemic. He also served as a medical director at the Cummins LiveWell Center in Columbus, Indiana for several years prior to his current role. Dr. Chestnut earned his MD and master's degree in occupational health at the University of Utah. He is residency trained and board certified in both occupational and environmental medicine and family medicine. Thank you to everyone for being here today.
All right, to the witnesses, again, we thank you. We take it not for granted that you give up your time and resources to be here to testify before your federal government in this subcommittee. I want to remind you that your written testimonies are going to be included in the record, but we are very eager to hear from you in your cogent 5-minute opening testimonies. Mr. Richards, you may proceed first with your testimony.
Thank you, and good morning, Chairman Booker and Ranking Member Braun, for this opportunity to talk about the challenges and opportunities that food as medicine presents for Kentuckians. An apple a day may keep the doctor away. Unfortunately, Kentucky consistently ranks in the bottom 5 nationally for diet-related disease and leads the nation in rates of food insecurity, with over 15% of Kentuckians living in food insecure households. Kentucky also ranks 50th in the consumption of fruits and vegetables, with only 4.7% of the state's population reporting eating 2 or more vegetables or 3 or more fruits each day. As a former farmer, this is unacceptable. Kentucky is a proud farm state with over 74,000 family farms, sixth most of any state in the country, and we should be able to feed our neighbors. To address these hunger and nutrition challenges, Kentuckians have undertaken innovative approaches from the grassroots to the Hunger Initiative launched by Agriculture Commissioner Ryan Quarles. My organization, Community Farm Alliance, CFA, was proud to launch Kentucky Double Dollars in 2014 and Fresh RX for Moms on Medicaid in 2019 as strategies for increasing the consumption of Kentucky-grown healthy foods for Kentucky families. These programs have been incredibly beneficial to recipients utilizing SNAP, WIC, and Senior Farmers Market Nutrition Program benefits to increase their buying power at farmers markets, community markets, and retail locations. From 2017 to 2020, this past year, over $900,000 in Kentucky Double Dollars leveraged the same amount in federal funds, putting almost $1.9 million into Kentucky farmers' pockets and creating over $3.1 million in economic impact for Kentucky communities, and we have just begun to scratch the surface. Equally important, 99% of Kentucky Double Dollar customers surveyed noticed positive changes in at least one of the 7 food-related behaviors that we measured, and 49% reported positive changes in all 7 behaviors. Food security has also been severely impacted by COVID and extreme weather events. Approximately 54% of KDD customers said that COVID made it more difficult to access fresh and healthy foods, but 82% said they began visiting farmers markets more often. The KDD program seems to have provided both consumers and producers in Kentucky with an important safety net during this time of uncertainty. The physical and human infrastructure that is developed around Kentucky Double Dollars has also played an enormous role in mitigating crises. During COVID, CFA, the Department of Agriculture, and other organizations were able to quickly provide farmers markets with additional resources and technical assistance that enabled many farmers markets to not only remain open, but made them safe places to shop. Following the historic floods of 2022, this infrastructure proved to be an important mechanism for getting food to those most impacted while also supporting farmers. It turns out building strong local food infrastructure is critical for communities to create food system resiliency in the face of adversity. Although Community Farm Alliance administers Kentucky Double Dollars, the program is a collaboration of many organizations. Besides the 70 KDD outlets, 26 stakeholder organizations make up the KDD Advisory Council to continue to improve this program. KDD funding is also diversified, with almost a dozen federal, state, and private philanthropic organizations having contributed over the past 8 years. The program's 2 largest funders, the Kentucky Agricultural Development Fund and USDA GusNIP programs, have been critical catalysts in helping many Kentuckians access healthy food. Sustainability for food as medicine programs like KDD and Fresh RX for Moms is an ongoing challenge. The USDA GusNIP grant program has been critical for CFA. However, with only $38.7 million available this year, just 8 GusNIP projects were funded. Unfortunately, Kentucky Double Dollars, along with many other applications, did not receive awards that could have had an extraordinary impact on our community's food and nutrition security. Without those much-needed GusNIP resources, we find ourselves asking how to sustain this work. Food as medicine represents a vast opportunity to help Kentucky farmers, communities, and those who are dealing with diet-related diseases. But federal funding for this work is critical. I would strongly urge the Senate Agriculture Committee to scale up the GusNIP program while reducing the match requirement in the next Farm Bill so that more food as medicine projects in Kentucky and around the country can reach their full potential in both rural and urban communities. Thank you again for this opportunity, and I look forward to any questions.
Thank you for your testimony. Ms. Penniman, rightfully awarded a Environmental Genius Award. No pressure, but we are looking forward to your 5 minutes.
Good morning, and thank you, Chairman Booker, Ranking Member Braun, and members of the subcommittee. I am honored to be allowed to speak before you today from my 25 years of direct experience as a farmer providing food as medicine to those in greatest need in our community. I'm the co-founder, executive director, and farm manager of Soulfire Farm in Grafton, New York, and a member of the Northeast Farmers of Color Land Trust and the National Black Food and Justice Alliance. I'm also a mother of two. As a mother, I know of no greater yearning than the sacred imperative to feed our children. When Emmett was a newborn and Nashima was just 2, we moved to the south end of Albany, New York, a neighborhood termed a food desert by the federal government due to the paucity of grocery stores, high poverty rates, and disproportionate burden of hunger, diabetes, heart disease, and other diet-related illness. Our family struggled to feed our children fresh fruits and vegetables, not for lack of effort, but because there was no accessible public transportation, grocery stores, farmers markets, or community garden plots. In getting to know our South End neighbors, we found we were not alone in the struggle to nourish our children. In fact, around 40 million Americans live in food deserts, where we cannot access or afford the life-giving foods that make us whole. When our neighbors learned that we were seasoned growers, they started teasing us, why not start a farm for us, a farm for the people? We took that challenge seriously and started exploring nearby land to see which parcel would claim us as friends and stewards. In 2006, we wed ourselves to 80 acres of eroded, degraded, affordable mountainside land in Mohican territory, which would become Soulfire Farm. We spent years healing the soil with cover crops and mulch, regenerating the forest, building a straw bale solar-powered home and education center by hand, and assembling a team. Soulfire Farm opened in 2010 from the collective yearning of Black, multiracial, and low-income families to feed ourselves. We established a sliding scale doorstep delivery program for vegetables and eggs that allowed members to choose how much to pay based on what they could afford. Starting with the south end of Albany, this Solidarity Shares grew and now covers 4 neighborhoods in Albany and 3 neighborhoods in Troy, reaching over 200 people every week. The weekly box reflects the bounty of the land's 100-plus heirloom and heritage crops like callaloo, Plat Tahiti tomato, and fish pepper. Our members grew inspired to learn to cultivate their own food, so we created a home gardens program that provides lumber, soil, plant seeds, and mentorship to aspiring urban gardeners. And we surveyed our members, and 100% reported every year that they were eating more fruits and vegetables and that health indicators like blood pressure and cholesterol were improving. They also reported increased feelings of overall well-being, energy levels, and a sense of empowerment. Local health clinics started to take notice and make referrals, as did the Refugee Resettlement Program. We couldn't meet the demand for no-cost and affordable doorstep deliveries of vegetables, so we started talking to other farmers and collaborating with farmers across the region. Folks like Corbin Hill Food Project, Rocksteady Farm, Poughkeepsie Farm Project, Schenectady Food Box, Sweet Freedom Farm, and Rocky Acres Farm became some of the many New York farmer-led food as medicine projects in our networks. Our farmers soon realized that our members struggled to afford even the lowest tier of a sliding scale pricing system, and when the pandemic hit, folks' capacity to pay evaporated completely. As farmers, we need to get paid for our crops in order to sustain ourselves and remain economically viable, but we couldn't charge our struggling customers, and we were not willing to drop them from the program because of their dire economic situation. And that's why federal nutrition programs are so important. The farmers in our network started collaborating and creating partnerships and working with initiatives like SNAP, the USDA Farmers to Families Food Box Program, GusNIP, and the Farm to Food Bank projects. These programs provide a way for farmers to access a steady and reliable revenue stream for our crops while providing food to at-risk families. It's a win-win. The farmer's able to stay afloat and communities can access nutritious food. In preparation for this hearing, I reached out to hundreds of Black, Indigenous, and people of color farmers in our national network to hear about their experience with federal nutrition incentive programs. Every respondent who participated said these programs are essential. By fully funding and expanding farm-to-community nutrition incentive programs, we benefit both the farmer and the consumer. And by increasing outreach to young farmers and farmers of color, we invest in the future of American agriculture. Those young children I mentioned at the beginning of my statement are now nearly grown up, with my eldest in college studying sustainable agriculture. She wanted me to tell you that, quote, the food system is everything it takes to get sunshine onto our plates. And as civic leaders, it's our responsibility to make sure that process is unimpeded. From the farmer to the food business owner to those with hungry bellies, it's our duty to move that sunshine along so that everyone can thrive. Thank you.
Thank you. Dr. Bolger, please.
Thank you. Good morning. I'd like to thank Chairman Booker, Ranking Member Braun, and members of the subcommittee for the opportunity and the invitation to participate in today's discussions on the challenges of food insecurity and food as medicine as a viable solution to treat chronic health conditions. My name is Dr. John Bolger. I'm the Chief Medical Officer of Insurance Operations and Strategic Partnerships at Geisinger. As noted, Geisinger is an integrated delivery system, so we have clinicians, hospitals. We also have a health plan, and in my role, I sit in between the two as Chief Medical Officer of the health plan, but also working on the clinical side. Geisinger has a long history of innovation impacting the health of populations. One of those interventions that we've championed is the fresh food pharmacy, which was developed with the following goals in mind. One, to improve healthy food access for residents in our communities with chronic conditions. We started with diabetes. Number two, to educate members on the connection between nutrition and health through clinical interactions and evidence-based programs. Number three, to reduce the burden of type 2 diabetes and related medical complications and optimize the use of prescription drugs and ultimately to lower the cost of medical care. Number four, to narrow the meal gap for those who are food insecure by ensuring participants have access to at least 10 fresh, healthy meals per week for them, but also for the other members of their household. And lastly, to collaborate with community partners to align and enhance the operations and the offerings of the fresh food pharmacy. So how does a fresh food pharmacy work? First, patients are screened in the primary care setting, one, to see if they have diabetes, and we took people who had a hemoglobin A1C over 8, which means they're at least 1.5 times higher than normal for their average blood sugar. We then asked people as well if they were food insecure and matched those people that had diabetes up and were food insecure, and then you qualified for the fresh food pharmacy. Those people were enrolled in clinical interventions like care managers, dietitians, diabetic education, and had consultants on the team. They were also given access to a facility, the Fresh Food Pharmacy facility, which offers healthy products that meet the American Diabetes Association recommendation, which includes lean meats, whole grains, fruits and vegetables, and limited sodium and cholesterol and fat content. And then the program provides enough food to cover 10 meals per week, as I said, for the patients, but it's also important that we provide those meals for the household members. So what are our results? How does it work? So we've had about 1,600 patients enrolled in the Fresh Food Pharmacy so far. Those are in 3 communities, both urban and rural: Scranton, Pennsylvania; Shamokin, Pennsylvania, which is in the coal region of Pennsylvania; and Lewistown, which is in a rural area in south central Pennsylvania. We screened more than 800,000 patients to get into the program. We provided almost 2 million pounds of food and 1.7 meals. And what we found is we can lower the patient's average blood glucose as measured by something called a hemoglobin A1C by about half on top of what they have. That's those beginning that were about twice as high as they should be, getting them to close to the normal range. We also decrease hospital utilization, so they end up in the hospital less, about 30% less emergency room visits, and as I said, improving their sugar. The one great example of this is the first person in the program, Rita. She's a 55-year-old widowed grandmother caring for her grandchildren. When she enrolled in the program, her sugar was about 3 times what it should be. She weighed 181 pounds, and her cholesterol was twice what it should be. After going through the program, she actually had normal blood sugars, so dropped her blood sugars by 2/3. She lost 50 pounds to 135 pounds and dropped her bad cholesterol from being twice what it should be to being about half the high end of normal. So building on, we've expanded the Fresh Food Pharmacy now to additional diseases like kidney disease and heart failure. Again, I'd like to thank you for the opportunity to present today on this critical health issue. We stand ready to be a resource at Geisinger for the committee on this issue, and we're really excited about the further discussion. For the benefit of committee, my written testimony provides further information on the fresh food pharmacy, and I'm happy to answer any questions you have. Thank you.
Thank you, Doctor. I'm excited about the results you're seeing as well. I'd like to now recognize Dr. Volp for his 5 minutes.
Good morning, Chairman Booker, Ranking Member Braun, and members of the subcommittee. Thank you for the opportunity to testify on behalf of the American Heart Association about why food as medicine programs are promising and why more evidence is needed. My name is Dr. Kevin Volp, and I'm the leader of the Planning Committee for the Rockefeller Foundation American Heart Association Food as Medicine Research Initiative and a volunteer member of the association's Advocacy Committee. I'm the founding director of the Penn Center for Health Incentives and Behavioral Economics and the Mark V. Pauley President's Distinguished Professor at the University of Pennsylvania's Perelman School of Medicine and the Wharton School. For 20 years, I served as a part-time primary care doctor and hospitalist at the Philadelphia Veterans Affairs Medical Center. Many of my patients struggled with chronic diseases such as congestive heart failure and diabetes, which were exacerbated by their challenges finding affordable, healthy food. As a behavioral economist, I've focused on testing strategies for improving patient health behavior and clinician performance. Through work with health plans, health systems, consumer companies, and individual patients, I've developed deep understanding about what physicians, individuals, and families need to promote health, prevent disease, and manage chronic conditions. As you know, chronic diseases represent 7 of the 10 leading causes of death in the United States, with heart disease as the #1 killer. These chronic diseases account for most of the nation's nearly $4 trillion in annual healthcare costs. The connection between nutrition and chronic disease is undeniable. For example, WIC has been shown to be associated with improved birth outcomes, lower consumption of added sugars and saturated fats, and improved academic achievement. Unfortunately, many individuals in the United States are nutrition and food insecure and do not have access to affordable, nutritious food. Food as medicine refers to diet-related interventions for patients with a diet-related health risk or condition and food insecurity to which they're referred by a healthcare provider or health plan. Evidence indicates that incorporating food as medicine programs into healthcare can be associated with improvements in outcomes. For example, medically tailored meals are associated with fewer hospital and skilled nursing facility admissions, fewer emergency room visits, and healthcare cost reductions. Produce prescription programs increase fruit and vegetable consumption and reduce household food insecurity. That said, there are important limitations in food as medicine research conducted to date. These programs have typically been evaluated in small-scale pilot studies. Many have been conducted using pre-post assessments of interventions without comparison groups, and the measured impact of such interventions may be overstated. Only a small number of randomized controlled trials have been done, and they've typically been small and thus unable to provide definitive answers. Food as medicine interventions have not generally incorporated freedom of choice and input from patients, reducing potential rates of engagement. And finally, these interventions have not generally been tested using intervention infrastructure or data platforms that are scalable beyond the context in which they were tested. To unlock the full potential of food as medicine, we must systematically answer important questions regarding intensity, duration, and delivery of food as medicine interventions, the role of patient preferences and choice, the incorporation of educational or behavioral strategies or coaching, the comparative effectiveness of ways to change behaviors and habits, and cost effectiveness. In conjunction with the White House Conference on Hunger, Nutrition, and Health, which came to fruition this fall thanks to your leadership, Chairman Booker and Ranking Member Braun, the Rockefeller Foundation and the American Heart Association have committed to mobilize $250 million to build a national food as medicine research initiative planned to launch in spring of 2023. We're designing a research initiative that will accelerate the speed of generating evidence on what works and for whom that can be used by public and private sector payers to inform coverage decisions. Working with patients and partnering health plans, health systems, food companies, and delivery services, we aim to create a platform for testing of ideas that significantly increases the availability of healthy foods to Americans no matter where they live, our collective ability to learn from studies by integrating heretofore separate streams of data, and that facilitates assessment of the cost effectiveness of different interventions for higher and lower risk populations. Chronic disease and unhealthy diets are inextricably linked. Continued federal support for nutrition research, including food as medicine, is needed to inform our efforts to prevent and treat chronic diseases, lower healthcare costs, and improve quality of life. Thank you for the opportunity to offer my perspective today and for your continued leadership. I look forward to your questions.
Thank you, Dr. Volpe. And our final witness and the third in our tremendous trio of doctors is Dr. Chestnut. You're recognized for your 5 minutes.
Chairman Booker, Ranking Member Braun, and members of the subcommittee, thank you for inviting me here today and for your interest in using food and nutrition to reduce death, disease, and disability. My name is Dr. Bob Chestnut. I'm the Chief Medical Director at Cummins. Cummins is a 100-year-old company with headquarters in Columbus, Indiana. While Cummins was originally known for diesel engines, we now have solutions in natural gas, hybrid, electric, fuel cell, and other technologies. We employ more than 70,000 employees globally in over 190 countries. We have manufacturing facilities in 10 states throughout the U.S. and a distributor network in almost every state. For me, growing up in a rural farming town in central Utah, Cummins was a household name known for quality and dependability. My hometown was a food desert. We had a single gas station with a few rows of non-perishable items, and few were healthy. The nearest grocery store was more than 30 minutes away. It was a town of farmers and craftspeople who worked hard, had poor access to healthful food, and could not easily prioritize their health. As I began my journey into the practice of medicine, I set about searching for how I could best help people like those in my hometown. As I looked around, I realized that employers have unique potential in supporting population and individual health. This is at least for several reasons. People spend a lot of time at work. Over 145 million Americans are workers, and most spend half their waking hours at work. This opens an opportunity for companies to be places of influence for encouraging and supporting healthier lifestyles. The next is alignment. The combined healthcare spending and lost productivity from suboptimal eating cost the economy $1.1 trillion yearly. Addressing diet-related health conditions may reduce absenteeism and presenteeism and increase productivity. Companies benefit directly from the improved health of their employees. And the last is a consistent health-promoting environment that may or may not exist at home or otherwise be available to employees. At Cummins, we are mindful that our success as a business is only achievable through the work of a healthy workforce. I will share several programs at Cummins specific to nutrition to improve health outcomes. In Columbus, Indiana, we have a patient-centered medical home. More than 10,000 employees plus their dependents live nearby and have access. When a person comes in with a diet-related disease like diabetes or heart disease, they meet with a doctor who is trained in lifestyle medicine in addition to primary care. This means that nutrition and lifestyle modifications are an integrated part of the person's treatment plan. The person will also be introduced to a team who provide multiple layers of support. They will meet with an ambulatory pharmacist who can optimize their medications and balance them with lifestyle changes. Our wellness coaches check in with them often and offer individualized plans for adopting new lifestyle behaviors. They can also be referred to our teaching kitchen to meet with our chef who provides hands-on experience with healthful food selection, food preparation, and health literacy. At many of our locations, we offer our Lifestyle 365 program. This is a 10-session hands-on experience focused on healthful foods, physical activity, and building health-promoting behaviors. Participants receive a prepared lunch of healthy food to try in each session. We also offer healthful cafeteria and vending items. Congress can take meaningful steps in helping the business community support nutrition and health initiatives. First, continue to include the business community in health discussions, exploring how employers may create health-promoting work environments. Federal support, like tax incentives on corporate food as medicine investments, would increase the ability of businesses to offer health products and services. Increased flexibility to offer telehealth and medical services across state lines would be particularly helpful to increase access to all of our employees. Congress can also support programs such as Total Worker Health by the National Institute for Occupational Safety and Health. Increased resources for the Total Worker Health Program could help businesses develop tailored, comprehensive health solutions, including increasing daily access to healthier food and lifestyles. Thank you again for the great honor and privilege of speaking to you all today. For more comprehensive background, please refer to my written testimony. If I can provide any more information on behalf of Cummins, I'd be honored to do so.
We are grateful for your testimony, everyone. We're going to jump right in with member questions. I'm going to begin with you, Dr. Bolger, not just because you have a great haircut, but because I am extraordinarily excited about Geisinger, which just brings such practical wisdom that should inform really government policy. You all have 3 brick and mortar locations and have provided healthy food to nearly 1,600 diabetes patients. And what is extraordinary is a paper that was written about your work shows that diabetes patients who take 2 or 3 medications, having access to your program, can expect their A1C to drop between 0.5 and 1.2 points, but that the patients at your fresh food pharmacy, in comparison to the people taking the drugs, we're seeing drops of over 2 points. And so that's an amazing comparison. People who do the drugs are seeing 1 drop, but you are seeing, just from the access to fresh and healthy food, 2 points. So can you explain to me, who has an honorary doctorate from Yeshiva University, that is true, but not a medical doctorate, what is A1C and what is a 2-point drop? What does that mean for the quality of health for patients?
Sure. Great. Thank you. It's a great question. The hemoglobin A1C is a measurement of your average blood glucose over about 3 to 4 months. So medical professionals use that to tell, instead of just doing a finger stick and seeing what you are right now, it actually gives us an estimate of what your sugars look like over a longer period of time. And of course, it's that longer period of time with your sugars being high that affects you and is as a chronic disease and changes things in your body, which create things like heart attacks and strokes, and, as you said earlier, vascular disease in the extremities, so you end up with amputations, those type of things. So a normal hemoglobin A1C is generally in the 5s, less than 6, and that equates to about an average blood sugar about 125. So for every 1 that you go up, it's somewhere between 25 and 30 for average blood sugar. So when you go to 7, it's a little over 158 and so forth. So if you want to get someone to normal, it's trying to get them to less than 6. Now, a lot of people with diabetes, the example I talked about in the testimony, that woman had a hemoglobin A1C of over 13, which meant her blood sugars were running in the 300s on average. And if your blood sugar is running in the 300 on average chronically, that's where you have significant damage being done throughout the body from that sugar. So by dropping it about, in the case of our situation, dropping it about 2.5 is dropping the hemoglobin A1C about 100, 150 points toward normal. So it's a big difference for people.
I mean, it's a massive difference. And so let's think about this for a second. Drugs, expense to the American public, that's one thing, but the health benefits. And what seems to drive Senator Braun and myself is obviously the human misery, reducing that in our country, having type 2 diabetes rates in our country where half of our population has got type 2 diabetes or is pre-diabetic. And as I said before in my opening statement, every month, 13,000 new amputations in America because of diabetes, 5,000 new cases of kidney failure because of diabetes, 2,000 new cases of blindness because of diabetes. This is a stunning set of numbers that I think drives Senator Braun, if I can speak for him for a moment, and I. But we also are concerned about the cost savings, and that's what is my last question to you is, there was a 2018 paper that detailed how Geisinger was seeing healthcare cost savings from this fresh food pharmacy program. Just really quickly, are you still seeing that cost savings from this program? As 2 guys who had to run stuff before we were senators, and that was one of our biggest concerns, was these growing costs. Are you seeing cost savings?
Yes, that's a great follow-up. If you look in the medical literature, as the hemoglobin A1C drops, cost drops. So we have seen that same thing with our program. The other thing we've seen, as I noted, is the patients end up in the hospital much less, which is one of the big reasons for healthcare costs. They end up in the emergency room much less, and we've seen them have a decrease in those complications you noted, like amputations, kidney disease, those type of things, and that all relates to the decrease in the hemoglobin A1C. So yes, we continue to see the cost savings around the use of food as medicine.
So you're fiscally conservative and liberal in healthiness.
Yes.
All right, Senator Braun.
Thank you. I'm going to start with Dr. Chestnut. How long has Live Well been in place at Cummins?
6.5 years.
That's a pretty good stretch of time to see if you're getting some results. Have you ever published that data so others can learn from it? And would you share what you've accomplished with it from when you started to where you are now?
So we definitely shared our activities and our programs and as best practices with others. As far as our results, we do track them internally, but do not publish them broadly. I can say we've had some tremendous results. We've had many individuals with diabetes who've experienced complete reversal, and many others who've had dramatic experiences with reducing the medications that they're on.
Have you incorporated free biometric screenings into what you offer your employees?
We have at various times, and so biometric screening, for an example, our Lifestyle 365 program, we do pre and post biometric screening. And so individuals will get their cholesterol checked, their hemoglobin A1C, and their blood pressure prior to those 10 sessions. And so what's impressive is that even that intervention, 10 healthy meals, 10 30-minute sessions of talking through lifestyle behaviors, we've seen individuals have a measurable difference between that pre and post, and see an improvement in those biometric data.
Have you found when you give your employees those tools, do they readily accept it, or sometimes do they need to kind of have time to sink in that they need to use that information? That's one thing we found early, is that even when you provided it, they didn't necessarily pay attention to it. What have you found?
So much of the same. We found that we need to create initiatives that meet people where they are, and we need to be consistent over time and keep our messaging ongoing. And an intervention for one group of employees needs to be very different than another. And so we have several unique groups within Cummins where we do have our manufacturing employees, our distribution employees, and our exempt employees. And for each of these, we offer different programs and different ways to engage to help them become mobilized in their own healthcare.
Even though you haven't published the arithmetic, which that was very important to me, I wanted to make sure what I was doing was actually going to be working in terms of the cost of it. Has it moved in the right direction in terms of your cost per employee per year, which should be the universal measurement when it comes to healthcare, and that it's making your employee healthier over time as well? So have you been moving in the right direction, even though you may not want to share the particulars of it?
Yes, we've seen improved health outcomes, and for the past few years, our employee premiums have stayed the same.
For the past few years? Would you say for the last 6.5 years?
I'll have to follow up with you on that to confirm where it's been over the past 6 years.
Well, the reason I emphasize that is we've done it for 15 years and not had to increase premiums and actually cut family premiums by a decent amount. So this works, but you got to get your employees to buy into it. The demand for remediation is very inelastic. If you have a bad accident or you get sick, employees, it's human nature, want to be fixed immediately. That's part of our system, what's wrong with it, because then you're in the highest cost per remediation that you can get when you don't get them to buy into the fact that you can prevent a lot of it. So I think a lot of what we need to do is not only from here, but to try to share. There aren't many like Cummins or Meyer Distributing that ever wanted to fiddle with it because it's part of benefits. It's hard enough to hire people when you're tinkering around with the health benefit plan. So we had to make a bold move 15 years ago, and it paid off. Sounds like you've done the same thing. And if we have a second round of questions, want to get into more of the macro issues.
We'll have a second round, but I just want you to
Okay.
clarify for the record. You keep saying we've been doing it for 15 years. You're not talking about the United States Senate or federal employees.
No.
Who are you talking about?
Our own company
Yes.
that I ran.
Yes.
Because it's not happening in enough places because folks like Cummins, folks like the company I ran, don't want to take the risk because the easiest way is just to provide the remediation regardless of the cost. And that's why we suffer from the highest healthcare costs in the country.
All right, thank you very much.
Yeah.
You are going to turn to Senate Superstar Smith.
Thank you so much, Chair Booker and Ranking Member Braun. It's great to be here with my colleagues in a terrific panel. I really appreciate this. I want to start with questions to Ms. Penniman and Mr. Richards. And so we acknowledge that it is hard to be healthy if you don't have access to healthy food. And the link between good nutrition and health is undeniable. And it's also what our grandma taught us. So the problem we have, it seems, is that our nutrition system in this country doesn't always support healthy eating, especially for people who rely on nutrition assistance. And these are also often not coincidentally the folks with the biggest health challenges caused by poor nutrition. So let's talk about EBT cards, which are like debit cards for people who are eligible for SNAP benefits. And they can be used not just in traditional grocery stores, but also farmers markets and other places where people can buy healthy food like fresh fruits and vegetables. And of course, then when they're buying from farmers markets or CSAs, they're also supporting the local food system, which has other benefits. So here's the thing that I want to ask you about. I'm hearing that EBT cards don't always work for farmers markets or at small vendors because of technology problems, challenges. So it's like a good idea that isn't executing because the technology doesn't work. And so my question is, are you familiar with this? What should we do? What can we do in Congress to fix this problem so that that EBT card is a ticket to healthy food and support for local food systems? Ms. Penniman, would you like to start?
Absolutely. Thank you so much for that question. So our farm has been accepting of EBT over the years, and we've made progress. You know, in the past, CSAs were not eligible. Farmers markets, it was very difficult to use them, and so I do commend legislators for paying attention to that. But when you come to food box programs, delivery programs, on-demand programs, there's still a technology mismatch. In order for me to go drop off my food, ring the doorbell, leave it at the doorstep of someone, I'm going to have to do a voucher system and then redeem it remotely later from my portal. And then if I don't use it for months in the wintertime, I have to go through a whole process of a store shutdown. And many of our farmers in our network have just said it's too cumbersome. It's not worth taking EBT. And moreover, many of the people who would want to use EBT, their benefits have run out by the middle of the month anyway, so without double bucks or some other supplementary program, we're running into the problem where we're footing the bill anyway for our recurring customers. So if we could modernize, get that system online, you know, allow for people to make orders of their produce online and pay online through EBT, I think it would do a lot to make it more accessible to the up-and-coming generation of farmers.
That's great. That's great. Mr. Richards, would you like to add to that?
Yeah, I mean, I think you've got to, well, you know, because we operate these programs in both urban and rural areas, and in particular Appalachia, you know, sometimes you're very lucky just to get a cell signal. But a lot of farmers are very interested in doing this, and, you know, one of the things that we have found is we provide technical assistance to those markets, right? So I think the Double Dollars program, they're attracted to it, they want to do it, but they're a little intimidated by the technology, right? So we do it, and you know, it is that warm body that gets up every day and helps make this stuff work, right? That is so important. That is like one of the third leg of the stool, besides the federal, you know, benefits and the incentives is, you know, the warm bodies who get up every day and make it work, whether it's the farmer's market manager or those kind of folks, right? People want to do it. and they're pretty resourceful to do it with
Right.
a little helping hand.
Well, thank you. That's very helpful. And Mr. Chair, I think this is an area where we could figure out work that we could do together in the Farm Bill to improve how this works so that it is actually delivering on the promise of connecting people with healthy food. So I'd love to work with everybody on this panel on this. I just have a minute more, and I have another question for Ms. Penniman. So this has to do with something that is near and dear to my heart, which is for tribal nations and for indigenous people, food is nutrition, it is also culture, and it is also sovereignty. And we know that if you have nutrition programs that are connected to people's the food that is part of their culture, then they are going to be healthier. And in fact, there is often a mismatch between the food that is delivered through distribution programs and the food that people want to eat, should be eating in order to be healthy. I hear about this on Minnesota's tribal nations and indigenous communities where distribution programs, for example, have the inclusion of milk when so many people are lactose intolerant. So my question is, from your work with food distribution systems, can you talk about what we can do better? I have a bill that is the SNAP Tribal Food Sovereignty Act, which would give tribes more control over their food distribution programs. Senator Booker is my one of my partners on this, but could you just address that briefly?
You have warmed my heart with that question, knowing that you're working on that. So I would never purport to speak on behalf of any indigenous or tribal nation. We do work in deep solidarity with indigenous nations, and we see the very same issues in the Black community, where school lunches, institutional food distribution programs are a mismatch for cultural foods, and the lactose intolerance the statement that you made is very pertinent also to Black community. I will say that small is beautiful in a lot of ways. So the farmers that we work with in our network, many hundreds of Black, Indigenous, and people of color farmers across the country, are growing the foods that their members ask them to grow.
Right.
That type of responsiveness is something that you can't necessarily get in a anonymized kind of distribution program. So every year we survey our members if they want fish pepper, for their soups, if they want callaloo, if they want Scotch bonnet, we grow that for them and we make sure that that's delivered. We have a wonderful Japanese monk in our program down the street, and if I don't grow her specific Japanese sweet potato, she'll come for me. So, I think that, whether it's because there is a direct relationship to the farm or the consumer, or because we've made focus groups and we make sure that what's in the box generally matches what people are asking for, there is no way to have success in these programs without some level of choice and cultural responsiveness. That absolutely has to be part of it.
Thank you very much. Thank you. We'll just say I took some of Senator Klobuchar's time.
Okay, understood. All right, there's been Booker, there has been Braun, but the best of the bees is Bozeman. I will always defer to the great senator, the star from the Midwest, Senator Ernst.
Thank you, Chairman Booker and Ranking Member Braun, and our chair, John Bozeman, as well. Thank you. This has been a great panel. Thank you all so much for being here. I really appreciate the time to talk and hear about some of the initiatives that we see across the United States. And I'm going to divert a little bit and talk about a pressing issue that we have out there as well, because this week we are going to be voting on the National Defense Authorization Act. And most recent statistics that are out there, only 23% of Americans aged 17 to 24 actually meet the necessary qualifications to enlist in our United States Armed Services. And there are many things that will cause folks not to qualify for military service. There's a lack of education, there's obesity, and other disqualifying health issues. But when you look at just obesity, out of those that don't meet the necessary qualifications, 27% are obese. And most of that is, of course, related to their nutrition and exercise or lack thereof. So I just wanted to bring up that issue. I know it's a topic for another day, but making sure that our children and young adults have access to healthy foods is extremely important, not just across the board, just because we want to be healthy Americans, but because of our readiness issues with national security as well. So I wanted to take that twist. But if we can come back to some of the programs that we're offering, many Iowans, both our children and adults, will suffer from digestive or inherited metabolic disorders. And I've worked with a number of families in Iowa that are dependent on medically necessary foods, vitamins, amino acids for their treatments. And unfortunately, the products come at a very high cost to those who depend on it. And that's why I am an original co-sponsor of the Medical Nutrition Equity Act. All Americans deserve to know that they are covered for their medically necessary nutrition under federal health programs and private health insurance to support their proper growth and development and to prevent other types of medical complications. I've also heard, as many have from Iowans, about incentives-based approaches as a preferred method to empower SNAP customers to purchase healthy foods. An example of this is the Healthy Fluid Milk Incentives Projects program, which I led and was established in the 2018 Farm Bill with the goal to help improve nutrition security for SNAP families through healthy and nutritious dairy products. And I also want to note that there is a project in Newark that I think Chairman Booker has maybe visited, and that's important as well. The dietary guidelines for Americans have repeatedly recommended milk and other dairy products as critical for a healthy meal pattern, and under this Healthy Fluid Milk Incentives Project, shoppers that use SNAP benefits to purchase a qualifying fluid milk product also then receive a matching dollar-for-dollar coupon to use for additional free milk or other types of healthy dairy products. And Mr. Richards, I see you nodding your head there, and I know that you are supportive of these incentive approaches for those nutritious dairy products. Can you talk a little bit more about those types of incentives or those types of projects?
Sure. Yeah, because I mentioned Kentucky Double Dollars, but it is actually 4 incentive programs, right? So there is the SNAP fruits and vegetables, which the GUSNIP grant has typically done. But we also double up WIC and senior farmers market nutrition programs. But then Kentucky is a livestock state too, right? So we double up meat. We have meat, eggs, and dairy double up for it because we recognize all those benefits and the fact that, you know, access to high quality, healthy protein is just part of a good diet. So it's all Kentucky grown meat, eggs, and dairy. That's for everything. But yeah, as a former livestock farmer, and my grandfather was a dairy farmer, so I'm right there with you, Senator.
Outstanding. Well, I appreciate it, and I am running out of time, so I just want to once again thank our panelists. Extraordinary. Thanks for what you are doing for your communities and, of course, for the greater health of our nation. We truly do appreciate it. Thank you, Mr. Chair. I yield back.
And thank you, Senator, for mentioning the Medical Nutrition Equity Act. It's also something I support and hope Congress will pass quickly. Yes. We turn now to Senator Klobuchar.
Well, thank you, Chairman Booker and Ranking Member Braun, for holding this important subcommittee hearing. And I'm looking forward to working with this committee in the new year on the Farm Bill and so many other things. And as we know, the committee has authorized and passed bipartisan bills on child nutrition many, many times through many different administrations. So clearly this is going to be a priority of ours. So I have a bill with Senator Lummis from Wyoming to better integrate mental health promotion and education in schools. We know that the spike in food insecurity may impact not only the nutritional needs of our students, but also their mental health. Can you talk about that connection, Dr. Volt?
For a lot of kids, they're living with horrible food insecurity, they're living with nutrition insecurity, and they're living in poverty. And that combination of factors clearly affects kids' mental health, it affects their physical health. And when you look at the data from WIC, you can see that not only do we see better nutrition intake by kids on WIC, you also see better academic performance. And I think that link of really trying to help the next generation get a better start so they're not susceptible to the same inequities of current adults is really important for us all to be thinking about.
Very good. A 2021 Minnesota Department of Health Workforce Report showed 80% of Minnesota's qualify as shortage areas for mental health professionals. We actually have the lowest unemployment rate in the country. 2 months ago, we had the lowest unemployment rate of any state in the country in the history of America. So we are down across the healthcare sector and manufacturing and the like. It's in some ways a good problem to have. There's good jobs out there, but it's also, especially in the healthcare area, becoming a real issue. It's one of the reasons I'm such a big proponent for immigration reform and for the Conrad 30 bill that I carry, which would allow people who are doing their residencies in the U.S. from other countries to stay. The Improving Mental Health and Wellness in Schools Act would help address these shortages. From your perspective, what else could be done to provide training and to get help in rural settings? Obviously, doing this, something we did in the pandemic, telecommuting and doing it via the Zoom and other platforms was helpful, but ideas on that front?
Well, I think more broadly, coming back to something Senator Braun said a few minutes ago, we spare no expense to treat disease once it happens, but we don't do nearly the same in terms of trying to prevent disease. And thinking more holistically about how we invest in people's well-being and both create incentives for them to have healthier choices, but also availability of services should they need them is really critical. The shortage in healthcare of mental health providers is really a crisis, but the larger question we have to ask ourselves is why do our kids need so much mental health services? You know, there seem to be real crises with anxiety, depression. What is causing that is really the question that we should be trying to answer.
Very good. Last question, just someone else on the panel can take it. According to the Centers for Disease Control, more than 42% of American adults, about 100 million people, had obesity issues before the pandemic. As we know, having just visited Mayo and talked to them about that, it's only upticked, I believe, since the pandemic. Nearly 3/4 of American adults have issues with weight. Roughly 1 in 5 kids have obesity. Furthermore, studies have estimated that nearly 2/3 of COVID hospitalizations are related to obesity and diabetes. What strategies can the committee consider as we move forward with nutrition programs to not only make up for lost ground during the pandemic, but to promote healthier lifestyles, healthier eating? Anyone want to take that? Except not Dr. Volpe, he answered everything. Okay.
Something that was frustrating for me in practice was that oftentimes the only weight loss programs you could enroll a patient in was the weight loss program that was associated with bariatric surgery. And so it was essentially a high-cost procedure that was subsidizing weight loss. And so it would be to uncouple that and provide or better fund deliberate weight loss programs that people could engage with.
Thank you. Anyone else? All right, thank you. Oh, Dr. Bold.
Yeah, I think, you know, and it was mentioned a couple times, I think, and one of the reasons why in the work we've done, we've provided food to the whole family is it really starts in the younger ages. And once you get to the point where you don't know how to, you don't have access to fresh foods and vegetables, you don't know how to cook fresh fruits and vegetables, it ends up being a lifestyle change over time. So I think really targeting at the younger ages and trying to change it from the bottom up, I think is one place to focus.
Very good. Thank you. Thanks, everyone.
Thank you, Senator Klobuchar. Senator Bozeman.
Thank you, Mr. Chairman. Thank you for having this hearing, you and Senator Braun. This is really important. Dr. Volpe, I was reading your, listening to you in the sense of being an old VA doctor, and you saw lots of patients, and you also, Dr. Chestnut, really kind of were saying the same thing that I'm trying to express. You saw lots of patients, lots of folks that drank too much, ate too much, smoked too much, and you did your best, to help them get through that. But you really weren't changing their behavior. I mean, that's really, in the sense, you're a busy practitioner, you're seeing patients, and it's just not part of it. My brother was an ophthalmologist, and before he became an ophthalmologist, he was a pediatrician. And he trained, it's been a while ago, but at that time, they really hadn't seen hardly any cases of type 2 diabetes in kids. That's rampant right now, as you all know. So it's really, this is just not an easy thing. And I'm struck by the panelists here. They're doing such a good job. You all have a systems approach. Senator Braun, had a systems approach. You just can't do this by, being a practitioner, prescribing this or that, handing somebody a prescription for vegetables or whatever. It just doesn't work. And so we really are going to have to rethink this and provide incentives, but the incentives don't work, to me, unless it really is an approach where you start changing its behavior modification. And we can do that. We're doing a good job. In fact, I think that we're ratcheting down too much on our school lunch programs, where children just, it's going to be equivalent to, if you're on a essentially a severe heart disease diet. But it's not only what you eat, in that regard, the good stuff, it's staying away from eating too much of the bad stuff, and so all of this goes together, and I'm really interested, again, and you being here, your great testimony, great work that you're doing, but what we've got to do is figure out, it's just not that easy. Again, to think that we can, I don't know that the BMI average of healthcare workers is any better than the general population, and certainly they know what's going on. The same is true of the farm community. They're out there in the fields and, have access to all this stuff, but like I say, their BMIs is not any better than anybody else's. So, will you comment on that real quick, Dr. Volpe? Because you're going to get into this. I'm excited about the fact that, and I want to learn more about the Rockefeller Foundation's effort to get into this. But I would just encourage you, like I say, whatever we come up with has to be more than the simplicity.
Yeah. Well, as you summarized,
especially with the children, which we're going to see the devastating effects of that. Because they are getting sick at a much earlier age.
Yeah.
That's going to cost society a great deal, besides their health.
Well, as you summarize, healthcare practitioners around the country are in this reactive mode of taking what comes and trying to do the best they can with the patients in front of them. But we don't have a system that's very good at being proactive and trying to prevent disease, change behavior. So a lot of what we're trying to do with the American Heart Association Rockefeller Fund initiative is figure out how can we really increase access to healthy foods, how can we create incentives, how can we make it easier for people to access those foods, and how do we determine what's sufficiently cost-effective that private or public payers would be willing to pay for that.
And to keep them away from eating too much of the bad stuff.
And that is one of the central
or
challenges.
Drinking too much or whatever,
Yeah, because we all pay for the consequences, healthcare cost consequences when people get sick, but we don't invest very much in trying to keep people healthy. And we need to figure out what evidence would help make that logical for either private or public payers to do more widely.
Very good. With that, I yield back, Mr. Chairman. And again, thank you for a really good hearing.
And I will thank you for that, and I'll turn to the very patient, marvelous Mr. Marshall.
Well, Senator Chairman Booker, thank you so much. But before I start, I just want to take a quick drink of the most wholesome, healthiest nutritional drink ever known to mankind. Here's to the farmers and the dairy folks. So I am excited to be here to talk about food as medicine. This has been a priority for my entire professional life. I think it'd be good to take a moment to pause what's working out there when it comes to food as medicine. I think the WIC programs are outstanding. Food banks are doing a great job. And more, there's opportunities for healthy choices at food banks. Meals on Wheels do an incredible job. Our senior citizen centers, where they get lunches, not only getting nutrition, but they're getting some psychosocial help there as well. Something else I've seen out there that's worked in the real world are the double bucks, rewarding healthy choices. So as we write a farm bill, I think it's part of my job as a senator to figure out what's working and how can we accentuate them. As we think about nutrition, I can't help but think about Medicare and Medicaid, that Medicare is facing a cliff, really insolvency in 2028. Medicaid funding is always a challenge up here. What would be the impact of good nutrition on Medicare and Medicaid? I want to submit for the record an article from JAMA. It's April 22nd, 2019. It's entitled, "The Association Between Receipt of a Medically Tailored Meal Program and Healthcare Use." An article that I read several years ago, and it demonstrates that the readmission rate for Medicare patients sent home with 10 tailored meals per week, that readmission rate was 20% of the control group. And if you think about it, the average cost for a Medicare admission is $13,000. So if there was 80,000 left of those, 80% less of those, how could that be used to fund good nutrition? Maybe making an investment of $400 or $500 to save taxpayers $13,000, and not to mention it's the right thing to do. So I think that's a great concept, and chairman of the all-powerful Ag Committee, as Senator Roberts taught me, and I are introducing legislation that would be a Medicare pilot project to do just that, to take a bigger group of patients, sending them home from the hospital with medically tailored meals. So I think that that's a great bipartisan opportunity. Next, Senator Booker and I think, are working on a project maybe that would attack more the Medicaid population. And specifically, I think there's the lowest hanging fruit are pre-diabetic folks. What could we send them home with? What should they be getting as far as a nutrition diet as well? So we look forward to continuing that discussion, maybe based on BMI. Let's not even do a blood test. Let's let them enter the program very easily, use BMI perhaps, and maybe follow up with hemoglobin A1Cs as well. So we're looking forward to that. And then Senator Gillibrand and I are working on getting milk back into the lunch program, specifically whole milk. We're going to have a generation of women that have osteoporosis and osteopenia in their 40s rather than their 50s because they're not drinking milk at school. So we want to bring that back into the program as well. This whole concept here reminds me about dynamic scoring and how the CBO doesn't use dynamic scoring, and how do we overcome that as well. I'm preaching to the choir here, of course. One of my concerns is that the FNS recently provided recommendations for WIC that included additional non-dairy substitutes for moms and children in the WIC program. Again, the WIC program, near and dear to me, something that my patients used every day. And I think this is contrary to the recommendations of increased consumption of dairy products in the dietary guidelines for Americans. And then I'm concerned about meatless Mondays and the impact of less protein in people's diets as well. So I think my question is for Dr. Volp. Do you believe meat and dairy are important sources of nutrients like protein and calcium for children and pregnant women?
It's a complicated question to answer. There's a lot of what you said I really agree with. The study you cite, I believe was a Berkowitz et al. Study, that really showed very impressive results in terms of medically tailored meals for chronically ill post-hospitalization patients. And I think those kinds of initiatives for the acute patients, post-acute care who are frail are really important. We also really need to think about programs for patients for primary prevention. So the patient with diabetes, who's not frail, but who would benefit from easier access to healthy food, subsidized access to healthy food. I think the questions about meat are complicated because there's some meats that are healthier than others. Saturated fat is obviously a problem for people with heart disease, and same thing with dairy. I think there are healthier alternatives in some cases, but it is very important people have enough protein in their diet, and so we need to figure out holistically how do you accomplish that given the full range of food options.
Yeah, I appreciate that. I just hope we don't forget, though, that we need to be able to absorb the fat-soluble vitamins somehow as well. I think for pregnant women especially, it's very important. Those vitamins A, D, E, and K are very important as well. So there are some good fats as well. I think I've passed my time. The last comment I would make is we almost need coaches as much as we need nutritionists and experts. I think most of us know what a healthy diet looks like, and we can make that more accessible, but somehow we have to get this coaching part of it as well, and changing lifestyles, changing healthy lifestyles, and that's where it tends to break down. Dealing with pregnant women is probably the only time I saw huge lifestyle changes, and that's because they had a secondary motivation. And the WIC programs, all those folks so involved. So how do we take that concept and expand it? It's been a question I've tried to answer for over 30 years, and maybe we'll make some progress. Thank you, I yield back.
You had a paper you wanted to be put into the record without objection. That's put in the record. Number two is you all know it's Senator Dr. Marshall, and he carries a lot of weight, I think, not on this committee, only on this committee, but also in the entire United States Senate, and your passion for medically tailored meals and your partnerships on both sides of the aisle. I just want to recognize how grateful I am to work with you on some of these key issues. We're going to go into a second round because Senator Braun and I are in charge. And so we're going to jump right in to Ms. Penniman. The more I've learned about food as medicine programs such as yours in New York, which really should be in New Jersey, the more excited I am for the potential of these programs, not just for the recipients of the healthy food, but also for the positive benefits that these programs can have for small family farms. So can you please talk about the benefits that your program has had on the farmers themselves, who are a group in America that are really struggling, especially independent family farmers?
Absolutely. Thank you very much, Senator Booker. So as mentioned, when you all called me up and asked me to come to the Senate for the first time in my life, I was nervous, so I asked for help. I called hundreds of farmers in our national network, and our network is small, beginning farmers, Black, Indigenous, and people of color farmers, to say, what are your experiences with this program? I got hundreds of responses. Everyone said these are essential, and I'll highlight a couple. I spoke with Corbin Hill Food Project, which is a New York-based Black-led food distribution program, and they're able to keep 200 regional farmers afloat with purchases through the GusNIP program. That's incredible. I also talked to Bill Thorne at Sky Island Farm, which is the largest Black producer in Washington State and a participant in the Farm to Pantry and prescription programs. And he said these programs keep small and mid-sized farms afloat. Otherwise, they primarily sell wholesale, and those outlets often don't take quantity, and they don't take quantity reliably. And so having that steady market is really important. As you mentioned, Senator, farmers in this nation are absolutely at risk. The average age of the U.S. farmer is now 58. For Black farmers, it's almost 62. And 96% of farmers are relying on our farm income just to survive. And when we're part of the National Young Farmers Coalition, which did a survey nationally of the up-and-coming farmers who we really need to pay attention to, or farming will die out in this country. And they said that, again, the supermajority of farmers are struggling to make ends meet. But importantly, 83% of young farmers are motivated by social concerns like ending hunger as one of the primary reasons they want to farm. And so there's a huge opportunity to connect these federal programs with these up-and-coming young farmers who are socially motivated, who want to make a difference in their communities, who care deeply and are connected. As we noted, these anonymized programs just don't work. People need to be in communities that have a culture of health. And these farmers are in community with folks who need this food and are ready to engage in that way.
Thank you very much. That's incredible firsthand testimony. Really quickly, Mr. Richards, you testified that your most recent application for GusNIP was not funded. Can you talk about what impact that loss of federal funding will have on your work?
Well, we are working very hard to minimize that impact. And I'm reaching out to many of our funders, right? But the fastest growing sector of the work is the retail, right? And most folks utilizing SNAP use their benefits at retail outlets. And we have worked at 5 retail outlets. 4 of those are members of the Independent Grocers Association in Eastern Kentucky, in which 40% of their customers are utilizing SNAP. So without the dollars to double up the SNAP fruits and vegetables just at those 4 locations, we're talking about, Eastern Kentuckians, Appalachians not getting almost $200,000 worth of fresh fruits and vegetables. We're talking about those same Appalachian farmers not getting almost $200,000 worth of sales. It's going to be pretty tough, right? And I think, even we have built this momentum up for over the last 6 years. And even a pause in it is going to destroy that, that kind of momentum in there. There's, for anybody in Kentucky, there's a story about the time that the bell pepper co-op, came in to help tobacco farmers. Instead of growing tobacco, grow bell peppers, and they formed a co-op, right? And all the farmers signed up for it, and then the co-op kind of like went away. So anytime you talk about something in Kentucky and you mention a pepper co-op, farmers are like, yeah, I know what you're talking about, right? I do not want Kentucky double dollars to be used in the same sentence as the bell pepper co-op.
Amen to that. Senator Braun.
Thank you. So when we were able to do, in the business I ran, I think, put in a solution that worked. It was in a broken system. There's nothing like healthcare as it's currently evolved into, where there's more lack of transparency, where there are barriers to entry to get into the business of healthcare at so many levels. Competition is growing less rather than more. And then I mentioned earlier, you don't have an engaged consumer. The classic market, if it's going to work, has to have full transparency to where the suppliers and the consumers have an equal amount of information. You got to have a lot of competitors, and you can't have barriers to entry that normally come from lobbyists. So we were able to tease out some of the transparency that is in the system on the fringes. Like if you pick up the phone, you get on the web, you can generally find savings of 30 to 70% on a lot of prescriptions and some of the procedures like MRIs, colonoscopies, CAT scans. If we could take the cost out of it, you could all of a sudden start investing more in the wellness portion of it. I'd like the opinions of a couple doctors that I haven't spoken to, Dr. Volp, Dr. Bulger. How much of our problem is the system itself, lacking the engaged consumer, having a delivery system that gives you none of the features of a competitive market, 20% of our GDP, 12% everywhere else, and if we brought that cost down, then you could start pouring resources into where it ought to be, prevention, wellness, and so forth. What do you think?
No, I think that's a great question. I do think, inherent in the payment system is you're paid for doing things.
Yep.
And not necessarily paid, well, you aren't paid in most cases for keeping people healthy. I think one of the things that we've been able to do in our neck of the woods at Geisinger, in the fact that we are both a payer and a provider, and one of the places where we, in that nexus of those two, where we created the Fresh Food Pharmacy, where we do both, I think one of the reasons we were incented to do that, because we were the payer, and we know that by focusing on prevention, you will decrease total cost of care. And on our provider side, then created something like the fresh food pharmacy. So I think that disconnect where the payment system is paying for doing things as opposed to worrying about the total cost of care and keeping people healthy. And I think that was probably one of the differences why in your business you did something different, because you were at risk for the total cost of care for your employees. So you said, what can I do differently here? And thought about prevention and how that would decrease total cost of care instead of worrying about what you were paying out.
And do you think the system as it currently exists, especially where hospitals have now grown to like 43% of that healthcare bill that used to be closer to 30, try getting some transparency to find out what that's going to cost. It's nearly impossible. And the fact that they don't make it easy, where else do you spend that much money and don't really have any idea what it's going to cost until you get your bill 2 to 3 months later, and then you hold your breath?
Yes.
And on the other hand, the consumer has no incentive because they don't have skin in the game. That's one of the features we created, so they don't shop around. When you see someone at a grocery store trying to save $1 on a $5 item, that is transparency. That is competition because it works there. I think we're kind of spinning our wheels because we know what needs to be done, but we got a broken system we're working within. Dr. Volpe, what do you think?
So a few additional observations. When you look across countries and you look at the combination of health and social service spending, the U.S. actually is right in the middle of the OECD countries. When you look at just health spending, we're an outlier.
Yep.
And as you know, we rank something like 36th in life expectancy. So we're trying to address a lot of issues by paying for expensive health care. And that's obviously not a very cost-effective solution. So I think really thinking critically about what do we pay for, how much do we pay, and can we encourage innovation of cost-effective ways to keep people healthy outside of healthcare is very important for us to do, and food as medicine can be part of that. Secondly, I agree with you that we need more price transparency. People have no idea how much it's going to cost them to go to the emergency room and get hospitalized. And if you're trying to encourage people to use urgent care instead of the emergency room, it'd be very helpful if people knew what the relative prices were ahead of time. So we could do a lot more with transparency and incentives to encourage people to use both lower cost providers and higher quality providers if that information were more widely available.
Most of those other systems are closer to a one-payer system because the clout of the payor has got a little more parity, with the system itself that provides health care. I don't think we need to go there, but if we don't fix it, and I think it's up to the healthcare industry to embrace transparency, competition, bring the costs down, and then have them, as the remediators, start promoting wellness as well. That's when we get to the best of both worlds. We're just so far away from it.
Yep.
All right, even though I've been warned by the higher-ups in the United States Senate that there's too much common sense being discussed at this hearing, it's very un-Senate-like, I just want to jump really quick to some just real speed rounds and so we can all get out of here. But real quick, Dr. Bolger, I think that both Senator Braun and myself focus on the data and follow the data, but I imagine there are things you're seeing that right now aren't really being measured. Your program, for example, the Fresh Food Pharmacy, is it having an impact on the entire family beyond just your patient?
It is, and I think one of the things we've seen is that, and we are beginning to measure this, is that our patients and their family engage much more in healthcare when they get the food. So the food is almost the carrot to bring them in and get them to engage with clinical nutritionists and nurses and other things which they wouldn't engage with necessarily if the food wasn't there.
So even though you're not measuring, you're confident this has a multiplier effect on the health and well-being of the entire
Correct.
family. And so you guys, it's common sense. You're looking at this in diabetes, but you're probably going to expand this program to patients with other diet-related diseases, yes?
Absolutely.
Yeah, because it would be malpractice of sorts not to try to continue to do that and expand it, correct?
Yes.
Thank you very much. Ms. Pettyman, this kind of, you talked about the impact that this kind of scale-up funding is having on a lot of different farmers. You surveyed your world. But just one thing we really haven't talked about is this growing reality in America that we have these massive healthcare disparities along racial lines in this country, where African Americans in particular have some of the lowest or highest morbidity rates on diseases. It's stunning that besides native populations, black men have the lowest life expectancy. So can you just really quickly give me a concise a thought on how this kind of funding would, for these key programs like GusNIP really have from an equity perspective?
Absolutely, and that's both for the consumer and the farmer. So, we work with low-income people of color populations that we distribute food to who have fibromyalgia, diabetes, heart disease, struggle with weight, kidney failure, and again, 100% of respondents over the 15 years of this program have said improved outcomes, right? But on the farmer side, we also have to reckon with the fact that the USDA has a huge racial equity issue, right? 97.8% of all government payments are given to white farmers. And in that National Young Farmers Coalition survey I mentioned, they were asking young farmers, how many of you have, of all races, how many of you applied for any USDA program? Half of them have never applied, and 75% don't even know which ones they would qualify for. And something that's fascinating, though, and there's historical reasons why, that are a little problematic for this, but farmers of color tend to disproportionately grow fruits and vegetables and raise livestock. White farmers disproportionately grow grain and oilseed crops. It has to do with access to good land and the history of that and the failed promise of 40 acres and a mule, right? So Asian farmers, black farmers, Latine farmers are growing these specialty crops disproportionately and are also underfunded by the USDA. And so there's an opportunity here by scaling up GusNIP and other programs that target these specialty crops in also starting to address the equity issues because farmers of color are the ones disproportionately growing these crops. We do have to make sure we're talking to these communities because there's a mismatch often in the growing season with the application process, with produce delivery scheduled in the winter months when there's no produce, with culturally inappropriate food. So it's not just as simple as increasing funding. We need to make sure we're talking to these farmers, but I think there's a huge opportunity to address inequity in funding farmers through these programs.
I wish we had more time to talk about that, but what you just said is so powerful in closing racial wealth gaps, closing racial health gaps, not necessarily a program that is targeted towards black people, but programs that are targeted to these larger societal problems, not only heal health, but also heal a lot of these historic divides. Last, back to Kentucky. It all comes back to Kentucky. Lastly, Mr. Richards, you are a farmer yourself. I love that you are a tobacco farmer. I'm never going to forget the bell pepper example. If I'm ever in Kentucky, I will never bring up the bell pepper co-op. Hi, I'm from the federal government. Let's talk about bell peppers. Will never come out of my mouth. But just finally, can you close us out with the high point of talking about really scaling up the GusNIP program as a former farmer yourself? Besides all the benefits the other doctors were talking about, could you just lastly, because it's a big rural divide, we talked about an ethnic divide, there's a real rural divide in this country. Could you please just allow us to understand how really scaling up will help rural America in a significant way?
Yeah, I can only talk about my experience, right? So as a tobacco farmer, every February, I got the letter, I got my quota, right? This is how much tobacco I could grow that year and market. And that set my whole year out, right? The infrastructure was there, all the technical TA was all there for me, right? When I started growing food, I didn't have any of that support system, right? I didn't know what I was gonna make that year, right? It was all completely unknown. So we at CFA, looked at the federal food and nutrition programs, the 14 of them that are in Kentucky, specifically how many SNAP dollars were coming into our state. And we thought, how can we leverage these federal food and nutrition programs to create the equivalent of the tobacco program for farmers who are growing food? That's how this work started, right? And so for why it's so important, like for these GusNIP funds, is because it creates a baseline of support that farmers know from year to year how much that they can expect to sell, right? And right now, well, this is December, right? But starting next month, folks are going to start ordering seeds. They're going to start planting the year. And for, almost 1,200 Kentucky farmers, that is dependent upon Kentucky Double Dollars and the Fresh RX program for moms. The other important thing, and I think as Leah said, is like for beginning farmers, for BIPOC farmers, right? Growing fruits and vegetables is it, right? Our state FSA office, recently testified that the fastest growing sector in Kentucky agriculture is from 1 to 9 acres. And that's because those are the folks that are growing fruits and vegetables as an entry point, and then they start scaling up. I could go on and on, obviously, but I'll stop there.
No, we appreciate that. Before I do the official closing, I just want to let everybody know this is the last subcommittee hearing of the 117th Congress of this subcommittee. I want to say for the record how much of an honor and a privilege it has been to work with Senator Braun. He has been a really powerfully, prodigiously pragmatic partner. How's that for alliteration? But really courageous in his willingness to step out there in a bipartisan way, whether it's with the White House, with me. You've just been truly a gift to me to as my first time chairing a subcommittee in the Agricultural Committee, and you've made this work not only more pleasant, but you've helped to push, I think, important conversations that we need to be having about how to make America greater, more healthy, more economically wise. So it's just been an honor to work with you, my friend, and
My pleasure to do it.
all right. I wish you the best on wherever your journey takes you. And then on closing to everybody, we would ask that any additional questions that anybody has to the staffs of the other senators that are here be submitted to the clerk 5 business days from today or 5 p.m. next Monday, December 19th. I want to thank the incredible panel that is here. You all have been extraordinary, and this hearing is adjourned.